Good morning, everybody, again. Would like to welcome you to the clinical symposium on thyroid. And my name is Mona Erikat, and I'm pleased to introduce our first speaker, who's joining us virtually, Dr. Carla Moran. Dr. Carla is a consultant endocrinologist and associate professor at University College Dublin, consultant endocrinologist, Beacon Hospital, Dublin, Ireland, and she'll be talking to us about, her topic is understanding unusual thyroid function tests. So can you please start the session? Thank you.
My name is Carla Moran, and I thank you very much for the very kind invitation to take part in your excellent conference. There's a very exciting program, and I'm delighted to be part of this. So I'm giving two talks in this session. The first is on understanding unusual thyroid function tests, and later on I'll speak about resistance to thyroid hormone. So I'll talk a little bit about thyroid physiology first and the type of thyroid function patterns that we see. My talk will be mostly case-based, so I'll illustrate my approach using these cases, and at the end I'll give you an algorithm for your approach to your own patient. I've not included resistance to thyroid hormone in this talk because, as I say, I'll cover this later on. So a brief recap on thyroid hormone physiology. You will remember that the hypothalamus produces TRH. TRH stimulates the production of TSH from the pituitary thyrotrophs, and TSH then mediates many of the steps in the biosynthesis of thyroid hormones from the thyroid gland. And T4 and T3 act to inhibit the production of TRH and TSH in a classical endocrine negative feedback loop. The vast majority of thyroid hormones circulate in bound fashion. So they're bound to thyroid hormone binding proteins. And these are TBG, transthyretin, and albumin. Free thyroid hormones enter the cell through thyroid hormone transporters located on the surface of the cell. And T4 is converted to T3 by deiodinase enzymes. And T3 then is the active form of thyroid hormone, and it binds to the thyroid hormone receptor, which is located within the nucleus of target cells. We're very familiar, obviously, with interpreting thyroid function tests, but if we see thyroid function tests that don't quite fit, either they're not typical of a common thyroid disease, or they don't fit with the patient's presentation, it's really important to think again about the clinical context. So the thyroid hormone status of the patient is important. So for example, in a euthyroid patient with a raised T4 and normal TSH, the first thing I would think about is assay interference. So your clinical impression of the thyroid status is important. There are physiological states that result in changes in thyroid hormones, and the most common of these are pregnancy. And so the reference ranges for T4 certainly will change in pregnancy, and that needs to be taken into account. The clinical context of the patient is important because if somebody is very unwell and in hospital, their thyroid function test can become abnormal due to non-thyroidal illness. And so this is an important consideration. And there are a number of medications such as amiodarone, biotin, heparin, and other medications that can cause unusual thyroid function tests. So a careful medication history is very important. Okay, so we'll go through the various thyroid function test patterns that we might see. So of course, initially the thyroid function test can be normal. A very common pattern we might see is a raised TSH with a low T4, and that of course fits with primary hypothyroidism due to any cause. A low TSH with a raised T4 and T3 fits with primary hyperthyroidism. And again, you'll be very familiar with the causes of hyperthyroidism. A raised TSH with a T4 in the normal range can be due to subclinical hypothyroidism. It can occur due to poor compliance with thyroxine or malabsorption of thyroxine. Medications such as amiodarone could cause this pattern. Assay interference can cause it. Non-thyroidal illness in the recovery phase, and a relatively rare condition where there's a mutation in the gene encoding the TSH receptor which can result in TSH resistance and can cause this biochemical pattern. So I'd like to move on to a case at this stage of a patient with a raised TSH but a normal T4. So this case was brought to light because her baby at the age of 7 days triggered a newborn screening test because the baby had a raised TSH. And the serum TSH at day 7 was very raised at 213 mU per litre. The pregnancy had been normal and labour had been normal also, and the baby had been born at term. But in the neonatal period, the baby had some dry skin, mild jaundice, but no goiter. You'll see that the TSH at day 11 was very raised at 826 mU per litre. The T4 was within the normal range. The baby started on thyroxine, and you can see that the T4 and T3 rose and the TSH did fall, but that T4, T3 response to thyroxine was a little unusual, and so further investigations were performed. So the mum's thyroid function tests were checked, and she also had a very raised TSH of 287 mU per litre with a normal T4, normal range T3 also, and negative thyroid autoantibodies. She had had no history of thyroid disease, she was not on any medication, and she had no goiter. So if we go back to the possible causes of such a pattern, this would not fit with subclinical hypothyroidism. The TSH is too elevated. One would expect a T4 and T3 that's very low if this was primary hypothyroidism. The mum's not on thyroxine, not on any amiodarone. And so we have to entertain other possibilities. And the first thing I would think about is assay interference. And I always think about this as the first possible cause if the thyroid function tests are funny or just don't fit with the clinical scenario. So assay interference in the TSH assay was suspected. So let's think about why that might potentially happen. So we have to recall how TSH is measured. So we measure TSH by sandwiching it between two antibodies, a capture antibody and a detection antibody. And the detection antibody is labeled. There are various labels that can be used, but essentially this is a way that we can then measure the amount of antibody that's present and that bound the TSH in the assay. And so the signal that is derived is directly proportional to the concentration of the TSH in the patient's serum. Now, it is possible that we can develop antibodies that sandwich these two antibodies. So essentially they behave like TSH and they act as a bridge between the antibodies. And so a higher signal is produced. And so a falsely elevated TSH result is returned. Another possibility is the presence of macro TSH. And so this is TSH that's complex to an antibody, immunoglobulin, IgG. And that complex is termed macro TSH. And you'll be familiar with macroprolactin. And this situation is highly analogous to that. So these patients have TSH that's complex to an immunoglobulin that's not biologically active. However, it can be picked up in the assay. And so again, a falsely raised TSH level is reported. There are various ways to investigate whether a patient has TSH assay interference. We can dilute the sample and see whether the TSH level is linear to dilution. We can add polyethylene glycol and perform PEG precipitation like we do for macroprolactin. And the gold standard method to determine whether somebody has macro TSH is to perform gel filtration chromatography. And indeed, this was performed in our patient, and macro TSH was confirmed to be the cause of the raised TSH. And this had crossed the placenta from the mum to the baby during the pregnancy. And so this is why it had triggered the newborn screening program. It would be expected that the baby would clear these macro TSH complexes over the following months and then later have normal TSH. And so this baby doesn't require any treatment, nor does the mum. It's estimated that macro TSH is present in approximately 1% of the cases that we currently contribute subclinical hypothyroidism as the diagnosis. So it's not terribly infrequent. The next pattern I'm going to mention is that of a low TSH with normal T4, T3, and that fits with subclinical hyperthyroidism. It can occur following treatment for hyperthyroidism. Some medications can cause this pattern, and also assay interference could be present, or a non-thyroidal illness. The next pattern I'll mention is a low T4 with the TSH within the reference range or low. And I think this is a particularly tricky clinical scenario. So I'd like to share a case with you of a woman that I've seen over the last year who had this pattern. So she was a 52-year-old woman who was referred to me because she was fatigued. And you can see her TSH was within the reference range, her T4 is low. So as endocrinologists, we often wonder, does this patient have central hypothyroidism? And of course, we're terrified of missing this diagnosis because we could miss ACTH deficiency, which is a life-threatening condition if undetected and untreated. So what are the potential explanations in this situation? So yes, the patient could have pituitary disease, either due to tumors or other insults such as vascular insults or previous radiotherapy. It's important to remember that 2% of the population will have a T4 that's below the lower end of the reference range, and that simply reflects the way that we derive reference ranges. So this patient could have a completely normal HPT axis and have no thyroid disease. Non-thyroidal illness can cause this pattern, and in outpatients, I often see this pattern in functional hypothalamic amenorrhea. Assay interference can again cause it. We can see it in recovery from thyrotoxicosis or in iodine deficiency. And medications can cause this pattern, and I'd particularly like to draw your attention to anti-epileptic drugs, including carbamazepine, valproate, and phenytoin, which have been described to cause this pattern. There are rare genetic causes, and I've listed those there. I'm not going to go through them in any detail, but it's worth remembering that these exist. So if I go back to my patient, so when I see these patients, I obviously take a history and perform a physical exam, particularly to include visual fields to confrontation. I'll review their medications to see if there's any medications that can cause this pattern, and previous TFTs can be helpful. It has been suggested that a fall in T4 of 20% over time is suggestive of central hypothyroidism. So it can be helpful to dig out previous TFTs. And I perform a laboratory pituitary screen. So my patient was on carbamazepine for a seizure disorder, and when I performed her pituitary screen and visual fields confrontation, these were normal. So I felt that this was related to her anti-epileptic drug therapy, and she was later changed to lamotrigine, and you can see that her T4 normalized. So this was an effect of anti-epileptic drugs and not due to central hypothyroidism. The last pattern I'm going to discuss is that of a raised T4 with the TSH in the normal range, or sometimes can be raised. And of all the referrals I get for funny TFTs, I think this is the pattern that causes the most difficulty. So I have a few cases to discuss when we think about this pattern. So the number one differential diagnosis in my mind for this pattern is assay interference. And it's the first thing really to exclude. And assay interference can arise for multiple reasons. It can sometimes be due to interfering antibodies, and I'll show you some examples of that. And it can also be due to abnormal thyroid hormone binding proteins. And the most well-described thyroid hormone binding problem that results in assay interference is FDH, familial dysalbuminemic hyperthyroxanemia. This pattern can occur with thyroxine replacement therapy, including due to poor compliance. Medications can cause it, such as amiodarone. Again, the non-thyroidal illness state can cause it. It's a typical pattern in the neonatal period. And rarely it can be due to a TSH secreting pituitary adenoma, resistance to thyroid hormone, or disorders of thyroid hormone transport or metabolism. So my third case is that of a 71-year-old man who had routine laboratory tests, and he was feeling well. He had a family history of Graves' disease, and he had a history of type 2 diabetes. He was on some medications for that. His BMI was a little raised, he had no goitre, and he was felt to be clinically euthyroid. So his TSH was within the reference range, but his T4 was elevated. And the referring clinician was concerned about this and started him on carbimazole. And you can see that his T4 lowered, but his TSH rose further. And the referring clinician was concerned that he may have resistance to thyroid hormone or TSH-OMA. So I wanted to exclude assay interference, so I initially took him off the carbimazole and repeated his assay. So from a blood draw taken on the same day, I requested TSH, T4, T3 in a number of different assays, as you can see here. And his T4, T3 are raised only on one platform, in the Roche platform. And his T4 and T3 are normal in all of the other platforms. And you can see that his TSH is persistently normal throughout. Notably also, his total T4 is normal. So this pattern fits with assay interference, and it would fit with the clinical scenario. He's not on medications that can cause this unusual pattern. He's euthyroid, and so this fits, I think, with his presentation. So this is T4 assay interference. So why might this occur? So I'd like to just go through how we measure free T4. And all the assays differ slightly, but the underlying principle is similar. So this is a cartoon explaining free T4 assay. In this case, it's the Roche assay where this man had assay interference. So endogenous T4 is indicated by the green diamond. T4 analog, which is part of the assay and is immobilized, is highlighted by the yellow diamond. And the assay contains an anti-T4 antibody, which has a label attached so we can detect it. And in the Roche assay, this label is ruthenium, which is an element. So what happens in the assay is that there's competition between the T4 analog and endogenous T4 to bind to the anti-T4 antibody. And in the case of a patient who genuinely has a low T4 level, the majority of the anti-T4 antibody will bind to the T4 analog. And only the bound antibody is measured. So the signal produced is high. And the key concept in measuring T4 is that the signal produced is indirectly proportional to the concentration of the T4 in the patient's serum. So this high signal would indicate to the biochemist that the endogenous T4 level is low. For patients who have elevated T4 levels, the majority of the anti-T4 antibody binds to the endogenous T4. And so a lower amount is bound to the analog. So a lower signal is produced. And so the resulting T4 is presumed to be elevated. And in the majority of cases, these assays work perfectly fine to estimate our T4 levels. A small number of patients can develop antibodies to ruthenium, which is the label in this assay. And the presence of these anti-ruthenium antibodies essentially affects the ability of these labeled anti-T4 antibodies to bind to the T4. And so a lower signal is produced. And so it's reported that the endogenous T4 is elevated. The prevalence of this is felt to be in 2 in 1,000 individuals in the Roche assay. So it's not terribly common, but when you think about how often we measure free T4, this is something that we will see not infrequently as endocrinologists. So this man had antibody interference in the Roche assay, but the other T4 assays were dependable. So when you think about isolated raised T4, always think about assay interference. So there can be antibodies to the thyroid hormone itself, anti-T4 antibodies. There can be heterophile antibodies. There can be human anti-mouse antibodies, or there can be ruthenium antibodies. So essentially, these are all antibodies that interfere with our ability to properly measure T4. And what might be a hint to you that your patient might have this is that you get varying T4 levels across different T4 assays. And that's very suspicious of assay interference. If the free T4 level is genuinely raised, it will be a similar level across the different assays. Medications can cause T4 interference, and a classic example of that is biotin. And so be careful to ask your patient if they're on biotin, stop it for a week and repeat the assay. And it's important to note that for biotin, actually it can lower your TSH, so it can mimic hyperthyroidism. Displacing agents can also cause raised T4, and these are medications that displace T4 and sometimes T3 away from the binding proteins. So you can have a raised T4, T3, and often it can vary a huge amount from day to day. And the hint here is that the TSH will be normal and also the total T4 is normal. And of course, you'll know that they'll be on a medication such as those listed here. And lastly, there are inherited causes of assay interference in T4, and these are binding protein abnormalities. So there can be mutations in the genes that encode albumin, TBG, and transthyretin. And here the binding proteins have an altered affinity for T4. And so this interferes with the equilibrium in the free T4 assay, and it often can result in an erroneously elevated free T4. The hint here is that often an increased amount of T4 is bound to the binding protein. So your total T4 is high and it's genuinely elevated. So I'd like to show you an example of that. This is my fourth case, an 18-year-old man. He had some diarrhea. So he had laboratory tests performed. He had no goiter, he was of normal weight, but he had a tremor. And so here you see again, the free T4 level is elevated in Roche with a normal TSH, normal T3. TPO antibodies had been checked and they were negative. So the first thing to think is assay interference. So he had T4 measured by other assays and they were normal. And he had a total T4 measured and this was elevated. So this made me suspicious that he had assay interference in T4, but that perhaps it was related to a binding protein abnormality because of this raised total T4. So we measured TBG and that was normal. So that leaves us with a possibility of an albumin mutation or transthyretin mutation. So we had genetic testing for both of these. And he was found to have a mutation in the gene that encodes the transthyretin protein. And this was a known mutation. And so his raised free T4 is a laboratory artifact. He has no thyroid disease, but it's very relevant for him, I feel, because the documentation needs to be very clear that he has no thyroid disease, but that his T4 may well be elevated when measured going forward. And also his family members should be offered screening for this condition, mainly so that they don't end up with an erroneous diagnosis of hyperthyroidism or inappropriate treatment. So my last case is that of a 78-year-old male, and he was fatigued. So he had a 6-month history of cold intolerance, dry skin, and tiredness. He'd had a history of prostate carcinoma, and he was on an anti-androgen, and he had a slightly low heart rate. So I felt clinically that he had hypothyroidism. And his TSH is high, so it fits with that, but his T4 is also elevated. We measured his free T3 and that was low. And we also measured his anti-thyroid antibodies and his TPO is strongly positive. So really his clinical scenario fits with hypothyroidism. So the only figure really that doesn't fit on this slide is his T4. Everything else really fits with hypothyroidism due to Hashimoto's thyroiditis. So we need to look for T4 assay interference. So we measured his TSH and T4 in a number of different assays. And you can see that in the initial assay, which is listed at the end, last column, his T4 is raised at 44. And what you'll notice is that his TSH is raised throughout all of the different platforms. So his TSH is genuinely raised. His T4 is very variable though. So for some of the other assays at the other upper end of normal, but in the 3 two-step assays, his T4 is low. And the difference between 1-step and 2-step assays is that 2-step assays include a wash step. So if there are interfering antibodies, they will be removed in this wash step. And so 2-step platforms are less susceptible to interference than 1-step platforms. And so here his T4 was genuinely low, TSH was raised, and he had free T4 assay interference due to anti-T4 antibodies, and his underlying diagnosis is Hashimoto's thyroiditis. So I'd like to summarize my approach to a patient with unusual thyroid function tests. So it's important to revisit the clinical history and think about a possible explanation for the thyroid function test pattern, such as their age, so neonatal status, pregnancy, whether they're on thyroxine, be careful about medication history, and whether there could be any non-thyroidal illness. If the clinical history explains the TFT pattern. So for example, non-thyroid illness, then no further investigation is required at the time. If there's no clear cause, then I'm careful to reassess the thyroid status, and I try to think which measurement, if any, is likely to be erroneous. So the next step then is to exclude assay interference. And here it can be really helpful to discuss with your clinical biochemist and to mention to them that you're suspicious of assay interference. What would they recommend in terms of checking an alternate assay? Additional tests such as TPO antibody or total T4 can be helpful, as I've shown you. If assay interference is present, it's worthwhile thinking whether it could be due to abnormal thyroid hormone binding proteins, such as due to FDH, TBG, abnormalities, or transthyretin. Because if they are there, you could investigate in more detail and perform genetic sequencing. And if you diagnose that, you could offer familial screening. If no assay interference is present, that's the time to then start thinking about investigating for rare genetic or acquired thyroid disorders, such as resistance to thyroid hormone or TSH-secreting pituitary tumor. So we've gone through all of these different TFT patterns, and this is just one slide summarizing those. And these patterns have been discussed in the article that I've mentioned at the bottom here, which is free to download, and it covers in detail an approach to a patient with funny thyroid function tests. So I'd like to thank you very much for your attention, and I look forward to the Q&A session and to discussing these cases more with you. Thank you very much.